Hey everyone, and welcome to The Rational Republican, a podcast where we look at complex issues facing us here in Oregon and around the nation. We'll try to address issues from a nonpartisan perspective and view our disagreements through a lens of respect rather than tribalism or divisiveness. I'm James Ball. This is Nick Perlasky.
Hey listeners, how we doing?
Today's podcast is brought to you by ProLift Garage Doors. ProLift is your one-stop shop for residential and small commercial garage doors, from openers, springs, and rollers to full reinstalls. They offer same-day service on all garage door repairs with no extra charge for evenings or weekends. Serving the greater Portland metro area, call today and set up your free estimate at 503-558-6349 or at proliftdoors.com/Portland. Again, that's 503-558-6349 or proliftdoors.com/Portland.
On this episode of the podcast, we're honored to welcome Mr. Michael Cannon. Michael is the Director of Health Policy Studies at the Cato Institute, which is pretty outstanding that you gave us the time to come talk to us. So Michael, welcome to the show.
Thanks for having me. It's great to be here.
So we kind of got connected with Michael through a guest a few weeks ago, Sam Metz. So he's here in Portland and he's a Democrat. And so we talked about single payer healthcare and how we can get more people better coverage for less money. And, you know, I don't want to speak for Nick, but I have a pretty wide libertarian streak myself. And so I'm really interested to hear kind of the rebuttal of what the libertarian aspect of, or the libertarian thesis for healthcare is. So before we get into that, Michael, why don't you just give a minute or two just to give a bio, who you are, how you got into politics, how you got where you are, that sort of thing.
Sure, thanks. So as you mentioned, I'm the Director of Health Policy Studies at the Cato Institute. I've been there for 17 years now. Prior to that, I worked on Capitol Hill for the Republican leadership. Even though I was not a Republican at the time, I was a libertarian, and I made that clear to them before they hired me. And they said, fine, but you can only work on these issues where we agree with libertarians, and on these other issues like gay marriage and foreign policy and the drug war and all sorts of other issues, they said, you can't say anything about those. I said, all right, fine. Prior to that, I worked for a libertarian grassroots organization, and it was there that I really got into health policy. They hired me to do health policy. And it's sort of a funny story about how they hired me to do healthcare. I wanted a job working in public policy, not particularly in healthcare. But they offered me that position, and they say, you have to understand, you know, before you say yes, you have to understand the reason this position is open is because no one else wants it. I said, I don't care, I'll take it. And that's how I got into health policy. And it's an interesting thing because when you talk to people who work in health policy on the free market side, almost all of them got into health policy the same way. On the left, like Sam Metz and the others, they get into public policy because of healthcare. But people who support free markets and free market healthcare, they don't get into public policy because of that issue. They get into it for other reasons. And if they end up working in health policy, it's because they sort of fell into it or it fell into their laps. And I think that is both a cause and an explanation for where we are in healthcare in this country right now. The US health sector is so heavily, we could say socialized, we could say there's so much government involvement that it's very easy to demagogue free market ideas as trying to take away someone's subsidy and therefore take away their healthcare and leave them with less. And as a result, because it's so easy to demagogue, politicians that try to advance free market ideas end up losing elections. We've seen Democrats do that to Republicans. You're trying to cut taxes. You try to take Medicare away from grandma in order to provide tax cuts to the rich. So Republicans stay away from this issue, and because they stay away from this issue, you can't raise money in order to advance. It's harder to raise money to advance free market ideas. It's harder to draw people into free market advocates into public policy to work on healthcare. And it becomes this sort of self-perpetuating problem where because the government is so heavily involved in healthcare, it is harder to get people to advance the ideas that would get it out.
I noticed this during COVID, and I'm not sure if it's an American thing or like just a human thing. So we tend to have a bias for action. It's very hard to convince a broad group of people that, hey, we're going to do less and you're going to be better off for it in the long run. They want you to do something. I mean, just look at Cuomo in New York. I mean, he was made some terrible decisions at the beginning of COVID, and he almost got away with it.
Terrible life decisions. If we're going to talk about Cuomo's terrible life decisions in general, the guy is a serial sexual harasser.
Well, he has gotten away with it.
Yeah,
he has gotten away with those poor decisions. If he's going to be held accountable for something, right now it's going to be the sexual harassment. It's not going to be the poor decisions with regard to COVID, which is really interesting. That you can make policy decisions that cause so many unnecessary deaths, and you could stay in office. But if you're a serial sexual harasser, you cannot stay in office. The injury from one is clearly, I mean, they're both very bad, but the injury from one is clearly worse than the other. But the political system only disciplines the lesser politicians for the lesser of those. That I think is not only interesting but instructive.
I think that, I mean, you even look at red states in the COVID debacle, where I think they tried really hard to have the more hands-off approach. People can do their own thing, and they got basically bullied into taking mandates and having government involved in this decision, just because I think that bias. So anyway, back to so we talked about single-payer healthcare with Sam Metz, and he made a lot of good points. At least I thought. I mentioned before, I have a pretty wide libertarian streak, and I believe that when you are able to solve a problem with the free market, that you should solve it with the free market. Before you look to government can be the last resort for those corner cases that just don't really work well with traditional economics. And I kind of had prior to this conversation, had thought that healthcare is one of those things. You've got, when you have a life-saving drug, people are going to pay whatever it costs to get that life-saving drug. There's really no price discrimination. You can't. We're seeing this with insulin, where they're raising prices, and the people who use insulin to stay alive are complaining about it, but they don't really have any leverage because they need the insulin and they'll pay whatever it takes. So I'm curious to hear how you would solve a problem like that.
So we published an entire book on this problem of high prices in healthcare.
The title summarized in 30 minutes.
Sure. Well, and I better summarize it because it is a very thick book. But it's by two of our adjunct scholars, both law professors. One of them is also an MD. It's called Overcharged: Why Americans Pay Too Much for Healthcare. They start out with the most punchable face in America, which is Martin Shkreli's face. He's the guy who jacked up the price for Daraprim and then was very smug about it. They explained the reason why he was able to jack up the price for Daraprim, why insulin manufacturers have been able to jack up the price for those drugs, why makers of erectile dysfunction drugs, and on down the line. Sovaldi, never mind those other drugs, but Sovaldi, which is a life-saving cure for hepatitis C. The reason why these drug launch prices are so high and you see such rapid increases in prices for even generic off-patent drugs is because the government it's because of government involvement. If the government weren't getting so heavily involved in the healthcare sector, there's no way the drug companies could get away with these outrageously high prices. But the government gets involved in several ways that encourage drug companies to jack up the prices for drugs, encourage hospitals to jack up the prices for hospital services, and so forth. When it comes to drugs, the main way that the government gets involved here is, or at least the first way, is by giving pharmaceutical manufacturers marketing exclusivity, either through the patent system or through other mechanisms, so that no one else can offer that drug. No one can compete down the prices that the manufacturers charge, so they just charge higher and higher and higher prices. That has happened with colchicine. That's what happened with Daraprim. It was an off-patent medication, and the manufacturers got well, the manufacturers, colchicine got marketing exclusivity. I believe Daraprim was off patent. There were just no competitors because of some other government interventions. And so they jacked up the prices to outrageous levels. And patients who depend on these drugs, really have nowhere to go. Some of them try to go to foreign countries, and Bernie Sanders has led expeditions into Canada to buy more affordable drugs. But these are all government interventions that are allowing this to happen. The patent system, other forms of marketing exclusivity, the FDA grants to drug manufacturers. The fact that the federal government encourages excessive health insurance causes prices to rise. Before Obamacare mandated 100% coverage for contraceptives, the prices for hormones and oral contraceptives were falling relative to inflation, following the same sort of trajectory as over-the-counter drugs, and these are prescription drugs, following the same trajectory as those prices, so that they're falling relative to inflation. But as soon as Obamacare mandates 100% coverage for these drugs, and the manufacturers know that the insurance companies have to cover those drugs, they jack up the prices, because what are the insurance companies going to do? They can't drop coverage for those drugs. Their enrollees will be upset if they do that. They have to cover them. They have to cover them at 100% because the government said so, and so the prices rise. So excessive insurance contributes to this problem. And that's not just with drug prices, it contributes to excessive prices for physician and hospital services and so forth. And I touched on another way that the government helps keep these prices high, trade barriers. The reason Bernie Sanders had to load people on a bus to go up to Canada is because the US government prohibits you from buying drugs from a Canadian pharmacy online and having them shipped to your home on a regular basis, or prohibits retailers from doing that, buying drugs from Canada where the manufacturers sell them at lower prices, and then selling them, having them shipped here to the United States and selling them at lower prices here. The US government prohibits, to some extent, you from doing that on a personal basis and retailers from doing that on a commercial basis, because the drug companies like it that way. The drug companies want to be able to sell drugs at the highest possible price in the United States, and then the highest possible price in Canada. And they don't want the Canadian drugs coming back into the market to compete down these high prices in the United States. So they support this government intervention, and the health sector is just littered with these sorts of government interventions that are keeping prices for all sorts of health services high.
Well, I got a question.
So there was a line in one of the episodes of The West Wing, which gets frequently mentioned on this show or on our podcast. But one of the guys, so obviously it's a Democratic administration, one of the people says to the other, it's just criminal that drugs cost what they cost. It costs these guys, $1.10 to make each pill. And one of the other characters, who's also a Democrat in the show, says the second pill costs $1.10 to make. The first pill costs $100 million. And it's not like you're just going to a McDonald's where, okay, their unit cost is 50 cents and so they can sell hamburgers for $1 or whatever. At some point, there's years and oftentimes decades worth of research that goes into each individual. I mean, just look at the coronavirus vaccine. This is literally nothing short of a medical miracle that we found out about this in March. And by the end of the year, there was a vaccine ready to go. I'm sure, Michael, you could speak to how rare it would be to come up with something in 9 months that's as effective as the COVID vaccine. But there's we don't kind of have that conceptualized. All we see is kind of what's right in front of us. And like you say, when the prices end up being artificially higher because of government mandates X, Y, and Z, and insurance companies mandate X, Y, and Z, it's not just a hamburger. You see the prices drive up. And while it's a problem, you got to look at what you actually need to do to solve the problem, which is, a lot of times it's based on government involvement.
I was going to say, if you get rid of the patents, yeah. Sorry, I was just going to repeat what Nick said, but if you get rid of the patents and you get rid of the marketing, I forget what you called it, the marketing exclusivity.
Exclusivity, yeah.
Is there still an incentive to develop those drugs if somebody can just copy your manufacturing process once you've already perfected it and produced pills for pennies on the dollar?
So the first pill often costs not $100 million, but $1 billion, $2 billion. And everybody wants to pay for the second pill. Nobody wants to pay for the first pill. But if you don't pay for that first pill, you're not going to get the second pill or the third pill. And so you're right. You need to create incentives for people to make that first pill, to invest in the research and development of new knowledge about what molecules are going to cure what diseases. And the patent system exists to do that. Some of my conservative friends get upset when I say that the patent system exists to raise prices. That's the purpose of the patent system. They say, no, it's to protect intellectual property. But really, the supposed market failure that the government is trying to correct here is that there are the new information that drug research and development generates is not excludable, and it's not rivalrous. It's a public good. And Econ 101 teaches you when you've got a public good like that, then markets probably are not going to produce the socially optimal quantity because people will be able to use that at a very low price, and the people who generate that knowledge won't be able to profit from it, so they won't generate that knowledge. And the patent system exists to raise the price that the people who generate that knowledge are able to charge for it. So a patent system exists to raise prices, and that's how, and that's the patent system's solution to this public good problem. You give the people who generate that knowledge the exclusive right to sell it, and they will be able to charge prices that cover their in theory, that cover their costs of generating that knowledge. However, there are problems with the patent system. It's not as neat as that explanation makes it sound, because drug manufacturers don't just charge, they don't just figure out, oh, well, this R&D cost us so much, and if we divide that among the number of pills that we figure we're going to sell, we'll set the price here. Drug manufacturers don't set prices to cover their R&D costs. Drug manufacturers set prices to maximize revenue.
Right.
And there's a difference there. They will often set prices higher than they need to cover their R&D costs because they can. And the patent system allows them to do that. So that is part of what's driving the really high launch prices and price increases that we're seeing for a lot of patented drugs and drugs with other marketing exclusivities.
Yeah, I agree.
It's not the only, and so that's a problem with the patent system, is you can get excessive prices, not just higher prices, which is the purpose, but excessive prices where you are providing too much of a reward to R&D and maybe even getting inefficient R&D and innovation. So one thing that my colleagues talk about in that book that I mentioned, Overcharged, is another way to encourage that sort of research and development is to have the government hand out prizes to people who develop that R&D, and then let anyone manufacture the drug, and let competition drive down the prices of those drugs. So in essence, under a prize system, the government would pay for the first pill, but then everyone else would pay for the second pill, and prices would be much lower. That's an idea that Bernie Sanders has introduced as legislation. So I like to highlight the fact that here, a Cato Institute book, a libertarian think tank's book, is advancing an idea that Bernie Sanders has introduced as legislation. We don't see eye to eye on things like single payer, but we're open to ways of reducing the amount of harm government does to the market for pharmaceuticals by coming with alternatives to that system.
So next guest that we get on the podcast, we got to get Bernie Sanders on here. We'll get him on. We'll have him walk us through it. Michael, I'd be curious for your thoughts. One of the things that I had read about you is that you are Obamacare's fiercest critic, which is, if I were you, I'd have had that tattooed on my forehead. I feel like that's the greatest thing anybody could ever say about a person. But I'd be curious to know, when we spoke with Dr. Metz on our previous episode, or penultimately previous episode now, I put that to him and I said, he agrees with you. He thinks that Obamacare was, for lack of a better word, a failure. And I said, I feel like that's interesting that the the bill that became law that was this massive shift, this massive takeover in a lot of aspects by the government of the healthcare industry is a failure. And his solution was to have more government takeover of the healthcare industry, was to just do more of the thing that, by his own admission, was a failure. To me, that I feel like that's a bit of flawed logic. But he says, no, the healthcare, it's so big that there is no room for the 50 states to be laboratories of democracy. There is no room to tinker around the edges with cutting red tape, or cutting costs and bureaucracy. We have to have this massive change. We have to affect this sea change. And this is the only way to do it, is to do it at the federal level and to have the federal government take control. I'm guessing that that's part of some of the reasons that you are Obamacare's fiercest critic, is you disagree with his take.
Yeah, so he's a great guy, and the pitch for single payer is a very attractive one, because you just pass one law and then everything is taken care of. You just give it all to the government, and then everybody, and the government will write checks for healthcare. We know they can do that. And because the government has taken it over, and we can rely on the government to write checks for healthcare, then everybody's going to have healthcare. It's a very simple, very attractive pitch, and it would do unimaginable damage to people's health, because healthcare is so complex. It is too complex for the federal government to manage. That framing that you used, that there's no room for 50 laboratories of democracy, the states to go their own way, is a weird framing, because what it assumes is that only the federal government is going to get this right. And the federal government is going to get this right for an entire country, because the federal government never gets anything wrong in healthcare, I suppose. Is that the argument?
Right. Never.
And the argument they make for single payer is that the best argument for single payer is the US Medicare program, which is very popular. And that's their vehicle for expanding health care to 330 million Americans, the single payer crowd. They just want to expand Medicare, give us Medicare for all. But if you look at the Medicare program, that idea should, if you look at it closely and look at the impact that it has had on the lives of seniors, that idea should horrify you. Because the Medicare program has not been a huge success. Yes, 66 million enrollees are utterly dependent on that program, but that's not the same as popularity. They're dependent on that program because the government is crowded out of their alternatives and driven up the cost of healthcare so much that people can't afford it without these subsidies. And the Medicare program has played a role in those rising prices.
It also doesn't pay as well as anything else, right? The payment to doctors is considerably lower, and it's really almost subsidized by
so this is
insurance,
this is a persistent myth. This is a persistent myth. Okay. Look, when it comes to the price for anything, no one knows what the right price should be. That's why you need markets and market competition, because what market competition does is it pushes the price in the right direction. Whether it errs, when the price is too high or too low, Adam Smith's invisible hand pushes it toward the optimal price, which is the price that generates the socially optimal level of Band-Aids or cardiologist visits or knee surgeries or what have you. And everyone assumes that because private prices are higher and Medicare prices are lower than those private prices are, that Medicare is like a better negotiator, that Medicare is getting closer to the optimal price or something like that. But
it's just a monopoly.
Or often you hear this critique that Medicare pays too little. And who do we hear that critique from most often? Well, doctors. But there's lots of evidence to suggest that not only does Medicare not pay too little, it pays too much, as often or more often than it pays too little. So the government setting prices for healthcare through the Medicare program, it's going to get them wrong. It's going to set them too high in some places, too low in other places, because it doesn't have the price mechanism that Adam Smith and Friedrich Hayek talked about, that pushes the price to that socially optimal level. Medicare sets prices is based on the political power of the various actors involved, And the people with the most political power there are physicians, as also hospitals, particularly physician specialists. And so Medicare, because they have so much power, Medicare ends up setting the prices for the services at those uh, uh, for those services probably higher than we would see in a market. There's lots of evidence to show that Medicare doesn't set prices too low for certain services too low. It sets them way too high. But the biggest problem with Medicare is not even the prices. It's not on the cost side. It's on the quality side. The Medicare program has had a negative impact on the quality of healthcare for seniors and everyone else in this country. It has prevented the sort of quality improvements that would be saving lives and caused a lot of people to die unnecessarily. Far more than have died, probably far more than have died this year due to COVID-19. If you look at and here's how that's happened. When Congress enacted Medicare in 1965, there's already a lot of evidence of low quality care in the United States. Some people estimated that poor surgical procedures cause 75, 100,000 deaths per year. Unnecessary, avoidable, preventable deaths. What Medicare did was it decided to subsidize healthcare, but instead of giving consumers the money and letting them decide how to spend it, which is what they could have done. They could have just expanded Social Security, expanded Social Security to give seniors a bigger Social Security check and say the delta here, the additional amount you're getting is for health insurance. We'll give sicker people a bigger bump so they can afford the higher premiums insurers will charge. Instead of doing that and then letting competition for seniors' healthcare dollars drive the market toward higher quality care. What Medicare did was they said, all right, we're going to be the one, Congress said, we're going to be the ones buying the healthcare. And we're going to come up with a single set of rules for how we're going to buy healthcare. They're going to be fee for service rules, which is because that's what the physician lobby likes. And they were explicit about that. In order to get the doctors on board, they were going to pay doctors the way doctors like to be paid. And the way they pay doctors is fee for service. So you provide a fee, you get a service. You provide another fee. I'm sorry, you provide. I've got to bet the horse before.
Right. Yeah.
Get the horse before the cart. You provide one service, you get a fee. You provide another service, you get another fee. And the more services you provide, the more fees you collect. Doctors love that way of getting paid because they have more autonomy. They can increase their incomes. But there are perverse incentives here. If a doctor fails to provide you preventive services that would avoid additional services down the road, they get paid more for doing that, for providing low quality care. They should get paid less, but fee for service pays them more. If they injure you such that you require additional services, if they misdiagnose you such that you require additional medical services, if they harm you due to a medical error, so that not only is there a side effect, but they actually made a mistake and you require more services, they should get paid less, and a market would pay them less. But Medicare pays them more if they do that. What that means is that if doctors try to invest in providing preventive care that avoids additional services, in improving their diagnoses so that they avoid additional services, or avoiding iatrogenic injury and medical errors so that they avoid further services, Medicare pays them less, and they suffer financially as a result. And so we haven't seen the sorts of innovations that would reduce all of those, that would push the market toward higher quality care in these areas. And as a result, we have estimates of deaths due to preventable medical errors in this country that run as high as 400,000 per year. That is more than the number of people who died from the novel coronavirus, from COVID-19 in 2020. And it is an order of magnitude greater than the conventional estimates of how many people die because of a lack of healthcare or health insurance in this country. So it's odd that before Congress passed Obamacare, we had people arguing, well, we have to cover people, we have to expand health insurance, when the government's expansion of health insurance, its largest expansion of health insurance, the Medicare program, is fueling a problem that is causing more deaths than the lack of insurance is causing. And the Medicare program is contributing to this problem, and would continue to contribute to this problem under a Medicare for all system.
I like the argument, though. I'm going to go talk to my wife, actually, and just say, look, I'm going to keep eating pizza and cheeseburgers and expect to lose weight, because the more that I gain, the more opportunities that I have to actually go through and lose the weight. And now every time, like, oh, look at me, I just dropped 3 pounds. Isn't this great? Because it doesn't matter that I put on 40 to begin with, but look at me, I dropped 3 pounds. I'm going to see if that works with my wife. We're going to see if I can make that argument.
I think those perverse incentives are kind of what drives a lot of the problems we see here in Portland. And I'm sure you've seen Portland on the news. We've been on the news about once a week nationally. The homelessness problem here is ridiculous, and we spend so much money on homelessness services, and they're all pay per service. Like you say, they're pay per person that they've seen. And so there's this perverse incentive to not actually solve the homelessness problem, but to just keep serving people so that they can keep their budget and they can keep hiring people and they can keep, and I'm sure,
passing new bond measures.
Right. There's not, pass new bond measures without a plan. There's not I'm sure people don't get into that business to perpetuate the homelessness problem, but I think they've got to be in the back of their heads that if all the homeless in Portland disappeared, that they'd all be out of a job. And that's got to be in the back of their head somewhere. And it's just kind of goes to what you're saying with Medicare. That's an interesting point I hadn't thought of. So what your solution would be, or solution's kind of you think it would be better off if we had private insurance, that if we expanded Social Security, for instance, gave everybody a couple extra bucks once you're retired to go out on the open market, purchase their own insurance, and then isn't insurance a pay per procedure as well?
No, not necessarily. Not necessarily. There are other ways of organizing, financing, and delivering medical care than the way that the Medicare program locked in place. You've got one of them in Oregon, Kaiser Permanente. In fact, I've got a former research assistant who's working at Kaiser Permanente of Oregon in their Medicare Advantage wing. This is the part of Medicare where Medicare contracts with private insurance companies. But the Kaiser model, which is essentially the same as the Veterans Health Administration model, although Kaiser's private, the VA is government, and the same as the British National Health Service, another example of this model launched by government, is the health system and the insurance company are all under the same corporate umbrella. So the same entity provides the insurance and owns the hospitals, hires the doctors, and so forth. And instead of getting, and when you have that sort of a system in place, instead of getting more money the more stuff you do, you get all the premiums you collect from your enrollees constitute the budget you have to provide health services for all of them, and whatever you don't spend, you get to keep. So instead of making more money by providing more services, they can make money by providing fewer. And you can see the obvious perverse incentive that exists there.
Right. I was going to say, I think you got the similar problem there.
Well, it's the opposite problem, actually.
Well, right, the opposite problem.
And healthcare is so complicated that you're never going to find a perfect way of paying providers that doesn't have any perverse incentives. But what you need is competition between all ways of paying providers, open competition on a level playing field, so that none of them can get carried away by their perverse incentives. So that if the fee-for-service doctors are providing too many services or exposing their patients to too many harms from those low-value, unnecessary services, and the premiums for that type of insurance are rising to reflect all those additional unnecessary services, consumers can walk across the street to a model like Kaiser, which is going to offer lower premiums and help them avoid those unnecessary services and the harms that often result. Meanwhile, if Kaiser goes too far by denying necessary services to people, those enrollees, the consumers, can go across the street to the fee-for-service providers. And what competition does is it forces each to improve on the dimensions of quality where they are weak, the dimensions of quality that their payment systems directly discourage. their payment system might discourage those dimensions of quality, but competition requires them to pay attention to those dimensions. We don't have that in the United States. We have the government heavily favoring fee for service. And as a result, we get so many of the harms that fee for service creates. And the Medicare program is one of the two biggest things the government is doing to favor fee for service and block the sorts of innovations that would, the quality innovations that would otherwise be allowing seniors and everyone else to lead longer, healthier lives.
So one issue I can see with that, a potential issue, and this is something that Obamacare tried to fix, which I'm not sure, I mean, obviously it didn't do great, but is the denial of coverage for pre-existing conditions. You know, once you get to a certain point in life, you basically have pre-existing conditions. Almost everyone does. And so if you're just giving people an extra payment to go out and buy health insurance, I mean, what's to stop the health insurance people from saying, you know what, you're going to cost $100,000 a month for the rest of your life. Just no, thank you. Would you just have to have some sort of legislation in place that would prevent that you have to accept people regardless?
Well, that's what Obamacare tried to do, and it didn't end discrimination against the sick. Obamacare is actually making discrimination against the sick worse, because it is telling insurance companies, we don't care if this person costs you $61,000 a year to insure, you can only charge them a $10,000 premium. That creates a $51,000 incentive for the insurance companies to do whatever they can to make their coverage so bad for those sick people that those sick people will go to their competitors and bring down their competitors' bottom line by $61,000. Economic research has shown that is happening in Obamacare. There is a race to the bottom in health insurance quality, and that is a form of discrimination against the sick. Before Obamacare, those $61,000 patients, and I'm thinking of specifically of MS patients here, those patients, if they had bought health insurance when they were still healthy, then gotten an MS diagnosis, the insurance companies would not have the same incentives to make their coverage worse for MS patients. Those MS patients would be getting better coverage than they're getting under Obamacare. So just passing a law saying we don't like this bad thing and
you can't do it anymore.
We're going to you can't do it anymore doesn't make that bad thing go away. The law of unintended consequences is a more powerful force than federal statute.
Well, I mean,
now,
so
your question about what do we do about those folks is important. If a Medicare enrollee costs $100,000 a month to cover, then the solution is that Medicare is already paying that cost right now.
Right.
And if we gave enrollees the money that Medicare is spending on their behalf in cash, then we should give more to those enrollees who are costing $100,000 a month. That's actually very rare that anyone's going to cost $1 million a year.
Right.
But let's say that, but it might happen. So if Medicare is going to spend that much on that person, what Medicare should do is just give the enrollee that money, and the insurance companies, if they can charge premiums that reflect actuarial risk, that reflect a person's expected medical expenses, they might charge that person, they will charge that person higher premiums, but that person would have the money that she needs to pay those higher premiums, because we're not giving her the average amount that Medicare spends on enrollees. The government would be giving her a Medicare check that reflects her expected medical expenses and would enable her to afford a basic package of health insurance that at actuarially fair premiums. And Medicare already does that to some extent. I mentioned before that Medicare contracts with private insurance companies through what we call the Medicare Advantage program. And when Medicare tells those private insurers you can only charge the enrollee, a community rated premium like Obamacare does. But then on the back end, Medicare provides additional payments to those insurance companies for patients that cost more. So really what Medicare is trying to do is it's trying to mimic market prices in health insurance. When you add up what the enrollee pays and the additional payment on the back end from Medicare, they're trying to mimic actuarially fair premiums, which is great, fine. But once you've done that calculation of what an actuarially fair premium is, there's no reason for the government to hold on to that money. They should just give that money to the enrollees, because then enrollees will be able to choose a package of health insurance coverage that better meets their needs, and in a market that doesn't create the sort of perverse incentives that Obamacare creates and even Medicare creates for insurers to have a race to the bottom in quality.
So what you're saying,
I'd be curious to know, actually, and I know we're kind of coming up on time. Is there any, like you'd mentioned Bernie Sanders earlier, is there anybody who's got legislation either there in DC or at somewhere at the state level? You know, Texas just came out with a good law, Florida just came out with a good law. Anything that you're kind of keeping an eye on as something you can hold up to say, like, this is an example of a good idea, or this is an example of good legislation?
So I'm actually not in DC right now. I'm in Bernie Sanders, Vermont. I would say Bernie Sanders' home state of Vermont, but his home state is New York. This is actually the trades. He's from Brooklyn.
We've got a senator like that too. Wyden lives in New York.
Is he from New York?
No, he's from here, but he lives there now, so it's a little.
Oh, okay, yeah, Bernie a little different. Although he's been here in Vermont, he's lived in Vermont for so long. Still hasn't lost that accent, but it's okay. I love the accent. So the question is there any decent legislation out there? And the answer is not much. In fact, legislation on the healthcare front appears to be getting worse. There were 25 years ago, some decent bipartisan attempts to move Medicare in the direction that I've been indicating it should move. Those have sort of fallen by the wayside. Also 25 years ago, Congress passed legislation to reform the Medicaid program, which is a program Congress created at the same time it created Medicare. It's ostensibly for low-income people, but there's a lot of middle and upper middle income people who are on that program. That legislation 25 years ago would have dramatically reduced the government's role, the federal government's role in that program. That has fallen by the wayside. Years ago, some members of Congress introduced legislation based on an idea that I had advanced to expand health savings accounts to let workers control $900 billion of their earnings that their employers currently control. Because there's a feature of the tax code that lets your employer control your money and use it to purchase your health insurance. I proposed expanding health savings accounts in a way that would let you control that money. It's about $15,000 per person with family coverage. So it's not an insubstantial amount of money. And in the aggregate, it's more than the federal government spends on the Medicare program. We haven't seen that HSA expansion reintroduced in this Congress yet, but this is something we're working on at the Cato Institute to bring more attention to these ideas so they gain more currency in the public square, and hopefully members of Congress do start introducing and enacting better legislation than we've seen them do with regard to healthcare.
Once they hear this episode, they'll be ready to roll.
I think that's going to put it over the top.
Well, I still have probably 3 or 4 questions that I would love to ask, but we are just about out of time. So one of the things that we like to do before we let our guests go is ask the question, who is your favorite Republican? Or I don't know if you are a Republican at this point, favorite libertarian politician? I don't know, pick somebody.
I don't like showering praise on politicians. Okay. There's even there is even to the extent where there is one former Republican, now libertarian politician who really impresses me, but I'm not even going to name him because I don't like, at the Cato Institute, we're nonpartisan. We don't get involved in politics. I don't want to start showering praise upon people who are involved in a really shady business. So let me do this. There's one libertarian who's a former colleague of mine at the Cato Institute, who's very active on social media, who has changed my thinking about a lot of public policy issues for the better. And I like to hold him up as sort of the paradigmatic example of what a libertarian is. His name is Adam Bates. If you find him, you can find him on Facebook. I think that's where he's more active, or most active. You can usually find him directly. If not, you can probably find him in my friends list or something like that. And he does a lot of work. He used to work at the Cato Institute in our Center for Constitutional Studies, or was it Criminal Justice? But he's now working for a refugee rights organization, does a lot of work on immigration. I have learned a lot from following him, and other libertarians disagree with him. That's fine, but I do like to point people toward his Facebook page as a good way to learn about libertarian ideas.
Got it.
Awesome.
Well, thank you so much for taking the time to come on the show with us. And yeah, it's been great. I think I've learned a lot. I got a lot to think about. So thanks again. And listeners, we will
Happy to
talk
do
to
it
you next time.
All right.
Thanks for listening to the Rational Republican podcast. Your hosts are James Ball and Nick Perlosky. The show today is brought to you by ProLift Garage Doors of Portland, serving the greater Portland metro area for all your garage door installation and repair needs. If you'd like to get in touch with the show, you can email us at james@jamesaball.com or follow us on Facebook, Twitter, or Instagram. You can find our episodes at jamesaball.com, Apple Podcasts, Google Play, or wherever you find your podcasts.